It's the top of the hour. We'll get started. I'm Dia Waguespack in Houston. I'd like to welcome everyone to today's GlomCon. Today is one of our clinical trials conference series, which is a joint venture between GlomCon and NephCure. And before we get to the talk and our speakers, just a reminder that NephCure is a organization whose mission is to accelerate research for effective treatments of rare forms of nephrotic syndrome and provide education and support that will improve the lives of those affected by protein-spilling kidney diseases. And one of the wonderful resources that NephCure has for both patients, family members, and clinicians and researchers is the Kidney Health Gateway, where you can search for trials related to the disease your patients or you may have and find trials that are active in your area to enroll in. So a great resource to continue to improve kidney health. So today our title is Targeting C3 and Immune Complex Glomerulopathies, Pegcetacoplan. Our speaker today is Dr. Hetal Kocinsky. She is a board-certified pediatrician and pediatric nephrologist working in drug development for more than 10 years. The majority of her drug development career has been devoted to studying complement inhibitors for renal and non-renal diseases such as C3G and PNH. She currently works on the clinical development of Pegcetacoplan, and I apologize for saying the name, a targeted C3 inhibitor for complement-mediated renal, hematologic, and neurologic diseases. She's a full-time employee of Apellis Pharmaceuticals. After her talk today, we will have a panel discussion. Our panelists are Dr. Anuja Java. She is Assistant Professor of Medicine in the Division of Nephrology at Washington University School of Medicine in St. Louis. She's a director of the kidney transplant at the John Cochrane VA in St. Louis. Her research involves conducting functional evaluations of genetic variants and complement-mediated diseases. Our other panelist joining us today is Dr. Marina Vivarelli. She's a pediatric nephrologist and associate professor of nephrology at Bambino Gesù Pediatric Hospital in Rome, Italy. Her research has focused on nephrotic syndrome and her clinical work on immune-mediated and complement-mediated renal diseases. She chairs the European Rare Kidney Disease Network Working Group on Immune-Mediated Glomerulopathies and a working group of the National Kidney Foundation on nomenclature of hemolytic uremic syndrome. She has treated the first pediatric patient with both eculizumab and with avacopan for different forms of C3G. So we're excited to have everyone here today. And with that, we'll get started with our talk.
All right, thank you very much for having me here to talk. I realize that actually both my name and the drug name are quite simple. So my name is Hetal Kocinsky, and I'll be talking about targeting C3G and primary IC-MPGN with a drug called Pegcetacoplan. Just as a reminder, Pegcetacoplan is an investigational compound for these diseases for C3G and IC-MPGN. It's not approved to treat these diseases by any regulatory authority. I will mention that we did recently get approval for Pegcetacoplan for the treatment of PNH in the United States and are pending a decision in Europe as well. Okay, so we're going to start by talking about these two diseases, C3G and IC-MPGN, and they have a very intertwined history. And so what I'm going to focus on today is not so much the history and the nomenclature, but to focus on the similarities and the differences between these two diseases. So C3G and IC-MPGN are both rare chronic kidney diseases that are thought to be caused by sustained and inappropriate activation of the complement system. And this leads to excessive production of C3 and C5 breakdown products, which are then deposited in the glomeruli, to kidney damage. And this kidney damage is devastating in the sense that many patients, up to 50%, will progress end-stage renal disease within 10 years of diagnosis. Renal transplantation is an option for these patients, but disease recurrence is common in the allograft, and in about 50% of patients will actually lead to allograft loss. Now, the diagnosis of these two diseases is relatively complex in that it requires both clinical and pathologic evidence. And so on the right, we have some pictures, some pathology, histopathology pictures, and we'll talk about histopath in more detail later in this talk. But the first picture shown here, and can everyone see my cursor? No. Yes?
Yes, we can see.
So this first picture here is light microscopy, and light microscopy typically shows an MPGN pattern of injury for both C3G and IC-MPGN. It's really immunofluorescence that distinguishes between the two diseases. And what's shown here on immunofluorescence is what these two diseases have in common, which is that they both have C3 deposition in the kidneys. So deposition of C3 breakdown products, and this usually the staining is for C3C. Now, the way they differ is whether or not, or to what extent, there is also immunoglobulin deposits. So in C3G, the deposition is primarily C3 breakdown products, whereas in IC-MPGN, you actually have either dominant or even stronger than C3 staining immunoglobulin staining. And then lastly, electron microscopy is used to distinguish between the two types of C3G, dense deposit disease and C3 glomerulonephritis. So these are diseases with a high unmet need because there's no approved therapy that targets the underlying disease pathophysiology in these and prevents progression to end-stage renal disease. So in talking about the underlying disease pathophysiology, as I said before, in both diseases, C3G and primary IC-MPGN, the underlying problem is believed to be overactivation of the complement pathway. Now, as a reminder, the complement pathway has three arms: the classical, the lectin, and the alternative. And all three arms then converge on C3. So when the complement pathway is activated, regardless of which arm starts the activation, you get activation of C3, which leads to its breakdown into C3A and C3B. C3A is a potent onaphylatoxin, which leads to inflammation, including within the kidney. C3B then also is found deposited in the kidney, but also goes on to form the alternative pathway C5 convertase, and so then allows the complement cascade to continue by breaking down C5 into its breakdown product, C5A, another anaphylatoxin, further increasing the inflammation, again, also kidney, and producing C5b, which goes on to form the terminal complement complex and also leads to damage within the kidney. Now, in C3G and IC-MPGN, in C3G, it's believed that the disease really begins within the alternative pathway. For IC-MPGN, it's sometimes believed to be the alternative pathway, often believed to be the classical pathway. It's possible that there's a combination as well. Regardless, what you see in both diseases is about half of patients have a low serum C3 because the C3 is being inappropriately activated and broken down. So you get low levels of intact C3. You can find excess levels of the breakdown products, C3 and C5, and you find the C3 and C5 breakdown products deposited within the kidney. Okay, so as I said, that these two diseases have an intertwined history, and they've gone through several nomenclature changes. And I like this figure from Cook et al. Because it shows maybe why the history is so intertwined and has gone through so many changes, because there is a lot of overlap between the two diseases. So, the two diseases have similar clinical presentation, features, and disease course. And they also have a similar disease pathophysiology in that they're both mediated by overactivation of the complement system. And this overactivation could be due to genetic causes or acquired causes. Now, in both diseases, an MPGN pattern of injury is the most common. So the two real distinctions between these two diseases is that in C3G, it's believed to be a disease primarily of the alternative pathway, whereas in IC-MPGN, both the alternative and classical pathways have been implicated. And then the other main difference between the two diseases is whether you find or how much immunoglobulin is found deposited in the kidney along with the C3. So in IC-MPGN, immunoglobulin deposition is either stronger than the C3 staining or similar to the C3 staining. And in contrast, in C3G, the C3 staining is stronger, considerably stronger than any immunoglobulin staining. So in terms of clinical signs and symptoms, many of the clinical signs and symptoms are those common to glomerulonephritis, like hematuria, proteinuria, hypertension, decreased GFR. As I already mentioned, about half of the patients with C3G or with primary IC-MPGN will have a low serum C3 due to the complement overactivation. And then some of these patients can have drusen, so an extrarenal manifestation where there are deposits in the retina that are presumably due to complement hyperactivity. So, what I want to illustrate in this slide is that the persistent and unchecked complement activity in these diseases leads to glomerular inflammation and then renal damage that can lead to chronic and eventually irreversible renal disease. Okay, so I said that the diagnosis depends on clinical and pathologic information. So from a clinical point of view, you want to have evidence for complement hyperactivity of some sort, whether that's based on serum C3 levels. You might find an autoantibody like C3 nephritic factor or certain mutations, but the biopsy is really essential for diagnosis, for making the correct diagnosis of C3G or IC-MPGN and distinguishing between them. And you do need all three modalities in order to accurately and completely make the diagnosis. So light microscopy in its own right is not diagnostic, although it does have a most common pattern of injury, which is MPGN. You can see other patterns of injury on light microscopy though. It's immunofluorescence that distinguishes between C3G and IC-MPGN, where C3G has C3 dominant deposits and IC-MPGN also has immunoglobulin deposits. Electron microscopy then distinguishes between dense deposit disease and C3 glomerulonephritis. So I'm sure most people remember that dense deposit disease has this very characteristic pathognomonic finding of electron dense deposits in a ribbon-like pattern throughout the glomerular basement membrane. And so if you have C3G and then you have this classic finding of ribbon-like deposits consistent with DDD on EM, then you make the diagnosis of dense deposit disease. If, on the other hand, you have C3G and then EM does not show these classic ribbon-like deposits, then you make the diagnosis of C3 glomerulonephritis. So now just to look at some pictures, we're going to look at all three modalities, light, IF, and EM. So this is light microscopy. On the left here, we have an image of normal glomeruli, normal renal cortex. And on the right, we have two images that are an MPGN pattern, where you can see the hyperlobulated glomerulus or hypersegmented with, the capillary loops that are no longer open like they are in the normal glomeruli. Okay, so by immunofluorescence, so what we have here are three different cases that meet the criteria for C3G. And what this is meant to illustrate is that in addition to having strong C3 staining, the C3 staining must be considerably stronger than the immunoglobulin staining. So this doesn't mean that you can't have any immunoglobulin staining in order to make this diagnosis as C3G. It could be, as in the instance of case 3, where you have some immunoglobulin staining, but the C3 staining is still considerably stronger. In contrast, if you have a case where the immunoglobulin staining is stronger than the C3 staining, then that would be consistent with IC-MPGN, or if they were equally strong, then that would also be considered IC-MPGN. So hopefully you can appreciate from here that the amount of immunoglobulin staining on the biopsy is basically on a spectrum, and it's the relative amounts of C3 and immunoglobulin staining that distinguish between C3G and IC-MPGN. Okay, so on electron microscopy, we can distinguish between the two types of C3G, which are dense deposit disease and C3GN. So this is a low power electron micrograph of normal capillary loops. And then this is the dense deposit disease. And I think you can best see it around here, this very dark ribbon-like dense deposit running throughout the basement membrane. And this is the classic dense deposit disease appearance. And then on the far right, we have subendothelial deposits you can also have some subepithelial deposits this is the way C3GN would look on the EM. And by the way, ICM-PGN would also look like this on electron microscopy. Okay, so as I said previously, there are no targeted therapies approved for C3G or ICM-PGN that target the underlying disease pathophysiology of complement activation and deposition of C3 in the kidneys. So treatment is primarily supportive, ACE inhibitors and ARBs to manage proteinuria and hypertension. Immunosuppressive agents are used commonly in an effort to curb the inflammation. And so steroids and MMF, for example, are used frequently in these diseases. Plasma therapy and exchange have been tried with mixed results. And then, of course, standard other measures for CKD like dietary changes. So it makes sense that if these diseases are due to overactivation of the complement system, then to study complement inhibitors in these diseases. And so what we have here is the largest published study of complement-targeted intervention. This study enrolled C3G patients, and it looked at anti-C5 therapy. So this study was done, it's a retrospective study from France, where they looked at 26 patients who got anti-C5 therapy, and half of these patients, about 13, were children or adolescents. So of these patients, about half actually had no response to anti-C5 therapy. And then about a quarter of them had what was considered a partial clinical response, and the remaining quarter had what was considered a global clinical response. So when they looked at the patients in these different categories, what they noticed is that those with a global clinical response were more likely to have more severe disease, lower GFRs, more rapidly progressive disease, and more extracapillary proliferation, consistent possibly with a more active disease process. In contrast, things like age, extent of renal fibrosis, whether or not they were nephrotic, and whether there were features of alternative pathway activation, like a low serum C3, did not differ between the responder groups. Now, importantly, when they looked at C3 deposition in the biopsy, this did not change with the anti-C5 therapy, regardless of whether they were responders or non-responders. So an expert in this field, Richard Smith, in a reviewer, has suggested that anti-C5 therapy serves as an anti-inflammatory, similar to other immunosuppressive agents in this disease, where it can address some of the glomerular inflammation, but has no or at best limited effect on the complement dysregulation that is the primary driver of the disease. Okay, so coming back to the complement pathway, and again, the three arms that converge on C3. And, we talked about the inflammatory, the anaphylotoxins that lead to inflammation, and then the breakdown products on this side of the figure that are found deposited in the kidney. So the drug that we're studying, called Pegcetacoplan, binds to C3 and prevents its breakdown into C3A and C3B. In addition, Pegcetacoplan actually binds to C3b. And when it's bound to C3b, it prevents the alternative pathway C3 convertase that would then break down C5. And so it has this dual effect. Now, it's important to mention here that the dose we're using of Pegcetacoplan in our clinical trials does not inhibit C3 completely. We estimate that it binds to 80 to 90% of circulating C3, leaving a little bit of C3 intact and available to be activated, for example, in the setting of an infection. Okay, so when we give Pegcetacoplan, then by inhibiting C3, we expect to be blocking the excess production of C3 breakdown products, as well as the excess production of C5 breakdown products. And our hope is that by inhibiting C3 and preventing this excess of C3 and C5 breakdown products, that we will address not only the renal inflammation, but also halt the deposition of these products into the kidney and allow the kidney to recover, which we hope will translate to reduction in proteinuria and eventually protecting the kidney to extend renal survival. Also shown here now are some additional targets within the complement pathway that are being investigated. So there are drugs that inhibit the lectin pathway specifically, or the alternative pathway specifically. And then, as you're probably familiar, there are drugs that target the C5 part of the complement cascade. Now, I think the thing to point out about pegcetacoplan as compared to all these other targets is that it targets the central part of the complement system. So pegcetacoplan should be should have efficacy regardless of which arm of the complement pathway is involved in initiating C3 activation, and also should be able to address the disease at the level of C3 and C5. All right, so with this, I'm going to tell you about trials that we have ongoing and planned for C3G and IC-MPGN, and we are studying these two diseases in parallel. We have 3 trials that we're going to talk about, and in order to put these 3 trials into perspective relative to one another, I'm going to put them in the context of the journey of patients with C3G, IC-MPGN. So if we think about C3G and primary IC-MPGN, and you think about a patient who's diagnosed with a biopsy, and then after some years or could be months, they develop end-stage renal disease and may receive a renal transplant. After some months or years, many of these patients will then have recurrence of their disease in their allograft. And then this can lead to allograft loss. And some patients will go on to have second or even third transplants. And once you have recurrence in one transplant, the risk of having recurrence in subsequent transplants is even higher. So the first study that we did with pegcetacoplan in these diseases was called the Discovery Study. And this study enrolled patients with C3G that was in the native kidney, biopsy-proven C3G in the native kidney. And I'm going to show you the data from this study. The second study, another phase 2 study, which we call NOBLE, is currently enrolling. And this study enrolls patients with post-transplant recurrence of C3G. And it includes patients with both C3G and primary IC-MPGN. And it could be a first transplant, a second, or subsequent transplant, but it must be a post-transplant recurrence. And then finally, we are just initiating a phase 3 trial, which we call Valiant, which will include the broadest population, which is C3G and primary IC-MPGN. It will include those with native kidney disease as well as post-transplant recurrence. And this study will also include both adults and adolescents. So I'm going to tell you a little bit about each of these 3 studies, starting with Discovery, where we have some data that we have previously presented at ASN. So Discovery is an open label study. It was actually a basket trial that enrolled patients in separate cohorts for C3G, IgA nephropathy, membranous, and lupus nephritis. But today we're going to focus on the C3G results. The primary endpoint was baseline in proteinuria, was changed from baseline in proteinuria to week 48 as quantified by the UPCR in a 24-hour urine. Secondary endpoints focused on GFR, serum albumin, and serum complement markers, including serum C3. So patients, and this enrolled adult patients and adolescents 16 and up. So patients underwent a screening period, and then all patients who were randomized were given pegcetacoplan. So this was a single arm open label study. The dose of pegcetacoplan at the start of the study was 360 milligrams daily by sub-Q infusion. And then by the time patients reached week 24, they had the option to switch to a twice weekly formulation, which was 1080 twice weekly. At the end of the 48-week period, if patients were receiving benefit from pegcetacoplan, they had the option to enter into a long-term extension where they could continue to get pegcetacoplan, and if not, they entered a follow-up period. So we enrolled 8 patients with C3G in this study. You can see there were both males and females. This was a relatively young population, and they were mostly white. So on the left, we have the data for the proteinuria. This dotted line shows you the mean change from baseline in 5 patients. So we show the efficacy data here for 5 out of the 8 patients. The other 3 patients, for one reason or another, had an interruption in their drug dosing, but not for safety reasons. And so then each of these colored lines shows you the change from baseline in proteinuria for individual patients. So if we look at some actual numbers here on the right, the 24-hour urine UPCR at baseline was 3.48 and at week 48 was 0.93. So the mean change from baseline in UPCR was around 70%. And then I also like to look at serum albumin in parallel with the UPCR. And you can see that the mean serum albumin at baseline was around the lower limit of normal, which is 3.5. And then by week 48 was nicely in the normal range at 4.08. And eGFR was stable for this 48-week period. So we also looked at some serum and plasma markers of the complement system. So shown on the left is the serum C3. So as I mentioned before, about 50% of patients with C3G will have a low serum C3. And this is consistent with the population that we enrolled. So about half of patients had a low serum C3, and by low, it was at the lower limit of detection. And about half of patients had a normal serum C3. And so the mean C3 was just below the lower limit of normal at, during screening and at day 0. And then when they received pegcetacoplan, then the serum C3 levels went up. And this is what's expected based on the drug's mechanism of action. So since the drug binds to serum C3 and prevents its breakdown, you expect serum C3 levels to go up. And this is indeed what we observe across different populations, healthy volunteers, PNH patients. But in this study, this is the first time that we demonstrated that pegcetacoplan can indeed do what it's supposed to do in this very dysregulated aberrant complement milieu of C3G patients. And so you see a nice increase in serum C3 levels. It does go above the upper limit of normal. These results are consistent with what we see in other populations. And then this elevation is sustained for the treatment period. You can see actual numbers for serum C3 here on the right. Serum C4 did not change. CH50 and AH50 did not change significantly, speaking to the fact that the C3 is not completely bound and there is some C3 still available to be activated and, for example, to respond to an infection. Now, I think it's very useful to look at C5b9 in this population because the serum C3 alone, is a mix of the disease as well as the drug's mechanism of action. So looking at C5b9 gives us a sense as to whether pegcetacoplan is affecting the terminal complement pathway, but also is another way to see whether the drug is inhibiting the complement system. So you can see that the C5b9 was actually quite elevated at baseline. So the upper limit of normal is 244 in this assay, and the mean was over 1,000, so quite elevated. And it came down nicely at week 48 was 385. So taken together, this is demonstrating that pegcetacoplan in this population does indeed prevent C3 breakdown and has effects all the way to the terminal complement pathway. And we believe that that is the reason that we were seeing reductions in proteinuria. Okay, so from a safety point of view, this drug was well tolerated in the discovery study. We had no serious adverse events, no severe adverse events, and no discontinuations due to adverse events. The majority of the AEs were considered unrelated to study drug, and there were no deaths during the study. And then you can see in this table the AEs that occurred in at least 2 patients. I will point out that there are patients who have local injection site reactions like some redness, some itching. These generally tend to be mild and transient and have not led to discontinuations from the drug in our studies. Okay, so now I'm going to talk about the second phase 2 study we're doing, NOBLE, which is in the post-transplant population. And this is a study that we are currently recruiting for. So this study will enroll or does enroll adult patients with post-transplant recurrence of either C3G or IC-MPGN. And the primary endpoint in this study is a biopsy-based one. So the discovery study did not do any biopsies on pegcetacoplan. And so what we want to know is that, we saw this nice reduction in proteinuria in discovery. We saw changes in serum and plasma biomarkers. But now we want to know, do we change C3c staining in the kidney? Because after all, that's the cardinal finding in these diseases. And we expect that our drug is halting halting this deposition, and we'd like to see if the C3C staining is reduced. I do want to mention that it's important that we stain for C3C specifically, because this is a form of C3 breakdown product that's transient. So if you see C3C staining, it represents really relatively recent deposition. So in this study, patients are screened, during which they will have a biopsy, or if they've had a recent biopsy, we can use that for the study. And then once eligible, are randomized 3-to-1 to either receive pegcetacoplan twice weekly or to be in an observational group until week 12, when they would undergo another biopsy to look at the primary endpoint of C3C staining. After week 12, all patients will be on pegcetacoplan. So those in the observation cohort will transition on to pegcetacoplan. And then at week 52, another biopsy will be performed, and we will look again at histologic and other endpoints. Like with the discovery study, patients who are receiving benefit from pegcetacoplan can continue in a long-term extension where they can continue to receive the study drug, or if not, can enter a follow-up period. In terms of secondary endpoints, we are looking at adverse events and safety. We are also looking at C3C staining at the 52-week biopsy. We're also looking at proteinuria, as well as stabilization or improvement in GFR. I'm not going to go through all the inclusion-exclusion criteria in the interest of time, but I do want to point out these two. So we feel it's important that we don't enroll patients whose disease is irreversible, because then we don't expect pegcetacoplan would be able to make a difference at that stage. So we require that patients have an eGFR of at least 30 and have no more than 50% scarring on their baseline biopsy. Okay, so this brings us to our phase 3 study, which we have just initiated in the United States and are hoping to initiate in the coming months globally. So this is a multi-center, randomized, placebo-controlled, double-blinded study. We aim to enroll approximately 100 patients. We will enroll adults and adolescents who have either C3G or primary IC-MPGN. It can be disease in the native kidney, or it can be post-transplant recurrence. The primary endpoint in this study is going to be the proportion of patients in active versus placebo with at least a 50% reduction in their UPCR at week 26, so approximately 6 months on drug. After a screening period, during which time there would be a biopsy. Now, adolescents do not require a biopsy, during screening. Patients will be randomized 1-to-1 to either pegcetacoplan or placebo for 26 weeks. At week 26, we will assess the primary endpoint, and then all patients will continue on pegcetacoplan for another 26 weeks. So the placebo patients will then transition onto pegcetacoplan at this point, whereas the pegcetacoplan group will stay on drug. At week 52, we will again assess endpoints. And then after this point, patients who are receiving benefit can again continue in a long-term extension, and if not, would enter a follow-up period. So we are evaluating, we do have a robust set of endpoints for this study since it's intended to be the registrational study. So, key secondary endpoints are looking at eGFR changes from baseline and proportion that are stable, looking at the C3G histologic index, specifically the activity score and how that changes in placebo versus active, and then looking at the proportion of patients in whom C3C staining is changed from baseline to week 26. We do have numerous other secondary endpoints, including looking at serum albumin levels, serum C3 levels, and various quality of life metrics. Again, I'm not going to go into all of the inclusion exclusion, but I do want to point out a couple of things. So we want to ensure that we're enrolling patients who don't have irreversible disease, but also have active renal disease with ongoing complement activation, because that's where we expect pegcetacoplan to have an impact. So if there is a screening renal biopsy, then at least 2+ C3 staining is required, so demonstrating relatively recent, robust C3 deposition in the kidney. If a patient doesn't have a baseline renal biopsy, and this is really relevant for adolescents, then there needs to be some other evidence of ongoing active renal disease as shown here. Like the other study, we will require no more than 50% scarring and at least an eGFR of 30. And then I will mention, actually, for all of our studies, we do require vaccinations against strep pneumonia, Neisseria species, and H. flu type B. These are the exclusion criteria. Again, I'm not going to go through these in detail, but they're here for reference. So in summary, C3G and primary IC-MPGN are rare chronic kidney diseases that are believed to be caused by sustained and inappropriate activation of the complement system, leading to excessive production of C3 and C5 breakdown products, and that these breakdown products are then found deposited in the glomeruli, leading to renal damage. Pegcetacoplan is an investigational complement inhibitor with a novel mechanism of action targeting the underlying disease process of C3G and primary IC-MPGN. And the data from the phase 2 discovery study are encouraging, and we believe support further investigation of pegcetacoplan in patients with C3G and other similar complement-mediated glomerular diseases like primary IC-MPGN. And so with that, I've told you about 2 additional trials that we're currently conducting in these 2 diseases. The NOBLE trial, again, is currently recruiting. It's a multi-center global open label randomized controlled study looking at post-transplant recurrence with a primary endpoint that is biopsy-based. And the phase 3 VALIANT study is just initiating a multi-center randomized placebo-controlled double-blinded study to look at safety and efficacy in C3G and IC-MPGN. So thank you for listening, and thank you to NephCure and GlomCom for this opportunity. I'd also like to thank families, caregivers, investigators, site staff, and all of you who are participating today. You can find more information about the 2 studies at these sites or using these QR codes. And with that, I'll hand it back over to Dia.
Thank you, Hetal, and thanks for excellent presentation. I think we have some great discussion points to get started on, and have Marina and Anuja chime in as well. So I think one of the places to get started is a question that was brought up by Dr. Glassick, and then again something we kind of commonly address, particularly here on GlomCon, is we see these patterns of injury, right? And you did a really nice job of differentiating the patterns of injury from C3G to IC-MPGN. I think the question is, and we can get everyone to kind of weigh in on this, is, there's heterogeneity in the diseases, and how do we incorporate this into one, drug development and what we're targeting for particular patients, and then I think from Marina and Anuja's work of what else are you looking at in patients when you're deciding or potentially deciding what therapies to start them on. And so Hetal, if you can start, and then we can have Anuja and Marina also give some input into that.
Okay, so this is a pretty broad question, I think, which is I guess I probably will defer to Marina and Anuja to kind of talk about what therapies are being started based on findings in the disease. And then the other part of the question, sorry, I couldn't see the chat while I was presenting, so I'm trying to.
I think just from the drug development, yeah, from drug development, because right now it looks like you're applying this to both patient populations, yes. Correct? And understanding the rarity of the disease as well, and enrollment. Yeah. But
so I think this is actually a really good question. And while we at Apellis kind of use the nomenclature of C3G and IC-MPGN, to be honest, what we're really trying to do is design trials that are enrolling patients in whom ongoing and persistent and inappropriate complement activation seems to be at the heart of the disease. And so, yes, we say we're enrolling patients with C3G and IC-MPGN, and that's true, but then we're targeting a subset where The C3C staining is intense. And by C3C staining, again, it's recent deposition of C3. And then we're targeting patients who, whose disease is active in some form or another. And I think that's the critical component for us in designing trials, is thinking about pegcetacoplan. It's a C3 inhibitor. So what's the subset of this pattern of injury where it makes sense for our drug? And that's what we've tried to make the inclusion-exclusion target.
Hi, good afternoon, good morning. This is Marina Vivarelli. I was rapidly looking through all the questions, and I did want to add just a little clarification on one of the questions that kept popping up, which was on whether drusen can be seen both in C3G and in IC-MPGN. And yes, it can. If you have a glomerular disorder in which you have a clear demonstrated role of the alternative pathway of complement being dysregulated, in all of those cases, you should look for drusen. And both in the historical cohorts of IC-MPGN, it is reported more or less with the same percentage as in C3G to have been found drusen. And even in our clinical experience, this is absolutely possible. So yes, if you have, irrespective of whether it's C3G or IC-MPGN, if you have a patient in which you have a dysregulation of the alternative pathway, you should check for drusen.
Thank you.
Coming back to Dr. Glassock's question about the heterogeneity, I think that's a very important question. I didn't want to put it in the chat. I think that's an outstanding question where we really don't know the answer clearly at this point. However, I think what's important for any of the complement inhibitors when we are trying to use is going back, if we can understand what's the defect that's driving the disease. And I think once that's clearly identified, then we know which drug to use. In general, what's known in the literature between C3GN and dense deposit disease is that, there's some data to show that for C3GN, there is more of that properdin dependent convertase. So there is maybe more of a distal defect versus a dense deposit disease, the convertase, which is properdin independent. So there is some thought that maybe dense deposit disease is more because of more of a proximal defect, versus C3GN patients may respond to more the C5 inhibition as well. But without knowing really what's driving in each patient, it will be hard to know. And that applies to any complement inhibitors. In addition to C3, we have so many other drugs in development. And I think when we know whether there's a nephritic factor, there's a genetic defect, it's going to be very precision medicine before we can really say which drug would be benefiting one or the other.
Thank you. And then kind of along those lines, Dr. Glassock, one of his follow-up questions was, is it, should we be thinking as pegcetacoplan as a disease modulating drug, or is it affecting the pathway for injury without altering the fundamental disease process? And I think some of what you answered kind of speaks to that, but if you guys can comment a little on that as well.
So I guess I'll take a first stab at it. And so, I think especially for C3G and to some extent for IC-MPGN, and I think, Anuja, you put it very well, that there's a lot of unknown still around really what initiates and perpetuates the diseases. And I think there's even the potential that in a given patient, it's not constant in terms of exactly where in the pathway maybe is most prominent. It could be changing over time. So, but the cardinal finding in these diseases is the C3 deposition, and it's believed that is sort of a very important piece of what is driving the renal injury. And so if that is the case, then preventing the C3 deposition would be expected to improve. And I think using a drug like pegcetacoplan is sort of the chance at addressing that and understanding whether we prevent C3 deposition, and then if so, if that's able to change the disease course. But Marina and Anuja, you guys can speak to this. I think, so far, based on the data, this is hypothesis as to the role that C3 deposition itself, or even C5 deposition itself, plays in the disease process.
I don't think I have a clear answer to that question on whether we can really safely use it as a disease modulating drug just yet. I don't know, Marina, what your thoughts are. I think as we know more data on the safety and tolerability of these drugs, I think overall they are safe. And I kind of put that in the chat on why I think it's not big a problem. But in terms of using them as modulators, I don't know if we are there yet. At least I am not able to answer that question clearly without getting more information on these trials.
Yeah, I completely agree. I think we need more data, and this is why running these trials is absolutely of vital importance. In theory, the only thing I feel like adding is that if you act more upstream, so you block C3, you would probably have a higher chance of being effective on all different forms of the disease. Whereas if you act more downstream, you would be most likely to be effective only in those forms where the C5 convertase is primarily activated. And this may be the reason why the anti-C5 blockers were maybe perhaps less successful than we initially hoped. But we just need more information. Hetal, one of the other questions that I'm seeing popping up that is definitely for you is whether or not you're enrolling in these trials patients who have C3G related to monoclonal gammopathies. And I believe not, but I think it may be better for you to reply to that.
Yeah, so you're correct. We are targeting primary C3G and primary IC-MPGN. And this is not to say that in theory, the drug may be effective in these diseases when they are secondary to something like a monoclonal gammopathy. But as I think you could probably appreciate from the slides, we're already targeting a pretty broad population. Again, kind of the widest population where we think pegcetacoplan makes sense initially, and then that's something we might pursue in the future, but we didn't want to add that confounding factor into these trials for now. So no, we do not enroll MGUS patients.
And one thought I have, just kind of thinking about, again, the modulating question is, and I again put that in reference to another question, there are other sources of C3. There is extrahepatic sources of C3. There is intracellular C3. And when we are thinking about a drug, whether it can modulate or kind of keep that balance, I think it's important to know how these drugs are going to affect those other compartments of C3. Will the patient have enough just to fight, have enough immune system to fight infections versus just kind of balance it out to prevent the dysregulation? And that's kind of where the modulation will come. And I don't think we are there yet to answer how these drugs will balance the immune versus the infectious part of it.
And then, Hetal, do you have a question, or there was a question about safety data in PNH, because you said it was approved for use in PNH. Do you have any of that you could share with us that we could maybe shed a little bit of light on what we may see in the future?
Yeah, so I think the PNH data set is our most mature data set. Actually, the safety data is presented in detail in the prescribing label, so that's available publicly. But again, overall, it was well tolerated in the PNH phase 3 studies. And I think the main thing to highlight, so I guess a couple of things. I think infection risk comes up obviously as a logical question with any complement inhibitor. Throughout all of our drug development programs, we have been very diligent and vaccinated for Neisseria, Haemophilus, and strep pneumo. But in that setting, in the PNH population where we have the most mature data set, we did not see any increased risk of infection, but we do recommend or require vaccination at the start of pegcetacoplan use, and that is what we do in our clinical trials as well. And then I think the other safety thing to mention, which I alluded to briefly, but is true from our PNH trials, is that we do see some local reactions at the injection site. These are generally mild and don't lead to discontinuation. So again, this was true in the PNH studies and can be found in the label.
If there's a short moment, I wanted to take up one of Dr. Glassock's questions that I thought was interesting and potentially very relevant, which is what happens when you interrupt pegcetacoplan? So you've brought the C3 back up to normal. Then if you interrupt, have you seen rebound in terms of proteinuria in the patients who have discontinued the drug? Or, what is your impression or your, limited experience from the patients who have been treated up to now from that point of view?
Yeah, so this is a really important question. I obviously don't have a definitive answer yet because it's limited data, as you said, but it is something I worried about, at first, but you're right. And we do have patients who have had interrupted dosing for various reasons. And what I can say is that none of them had any serious consequences to interrupting the dosing. So no patient had, serious adverse events or acute kidney injury requiring hospitalization or dialysis or anything like that. But I appreciate the question because it is something that I worried about. I think, and this is unlike PNH, where discontinuing or missing a dosing can lead to hemolysis. But in these patients, might the proteinuria go back up or might the disease be returning? Yeah, that's possible, but we haven't seen that these patients have serious events that are leading to, no serious adverse events on discontinuation. And I should say that the safety data, like while the efficacy data was in the 5 out of 8 patients, the safety data is in all 8 patients. So no serious adverse events, no serious infections, all of that is true across the 8 patients.
Hetal, can you just comment on the dosing and schedule and administration? Because there's some questions on that.
Yeah. So our ongoing clinical trials, Noble and Valiant, the dose will be 1080 milligrams twice weekly. That's also the approved dose for PNH. So we're studying the exact same dose. And I'm not sure exactly what the questions are, but by twice weekly, you basically have a choice of doing it Monday, Thursday, Tuesday, Friday, Wednesday, Sunday. Essentially, you pick 2 days of the week, and then you continue to do it those 2 days of the week.
And it's a self-administered subcutaneous injection?
Yeah, so that's a great question too. So it is self-administered. We do, we go out of our way to make sure that the site and then the patient are comfortable with the self-administration before we send them off to do it on their own. So the first administration is done at the site. The site is trained ahead of time. They then teach the patient. And then we provide home nursing services until the patient feels comfortable. Most patients actually are comfortable doing it after, they do it one time at the site, they have the home nurse come once, and then they're usually on their way. But some patients, are anxious. And so we will provide home nursing for a longer period if they wish.
And then you're enrolling patients, both treatment naive and those who've been on treatment before with the criteria you discussed, correct?
And I guess depends on what kind of treatment we're talking about, but there's no prior treatment that excludes you. You cannot be on another complement inhibitor while you're in this trial. So there is a washout period. If you'd been on eculizumab, for example, before, there are some other, you can't be on eculizumab, rituximab, or belimumab, essentially. Otherwise, you can be on steroids, you can be on MMF. We do ask that at the time you enter the trial that you're on a regimen that the PI feels they're going to be able to keep stable for the 26-week treatment period so that we can isolate the effect of pegcetacoplan.
And then you're collecting data on genetic defects in the complement pathway in the patients you're enrolling. Is that something that you will have data on?
So we are not doing genetic testing within the trial. We are doing C3 nephritic factor. We are looking at various plasma and serum complement levels, but we are not actually conducting genetic testing within the trial.
All right, thank you. Marina and Anuja, do you have any questions or comments? And then we can open it up to the audience to ask directly.
No, I've just been kind of following the chat, trying to get to as many as we possibly can. But
yeah, I would leave it to the patients now and to the audience.
Excellent. So I will change the setting. If someone has a question, please feel free to unmute and you can ask directly.
So I know there was one question and I would like to address this about the C3C staining and whether this is available in most labs. So I guess a couple of layers to this question. So first of all, for our clinical trials, yes, there will be a central pathology processing of the biopsy and review of the biopsy so that we can have a unified and systematic approach. And so that the C3C staining then will be done by the lab with a C3C specific antibody. In terms of what most pathology labs use, my understanding is that most are using, so the key is that you don't want to detect C3D, D as in dog, when you're doing this, because that's the version of the C3 breakdown product that is permanent basically and is going to persist. And so if your antibody is picking up C3D as in dog, then you can't assess changes or what has been recent. So most antibodies, I believe, that pathology labs use are either specific to C3C or detect C3C and C3b. And that's okay too, because C3b is very transient as well. The key is that it shouldn't detect C3d.
There are a couple other questions, Hetal, and I think they're simple ones. I just kind of wanted to make sure we address them. The trial is, are we enrolling treatment naive patients who've never had any immunosuppression? I know those patients who've been on stable immunosuppression can be enrolled. Can you talk about that?
Yes, so patients who are not on any immunosuppression certainly can be enrolled.
And there were any complement mutations done on any of the patients prior to the treatment? I didn't think that was part of it, right?
Right, so we're not doing genetic testing as part of the trial. If patients have had genetic testing previously, there are no genetic testing results that would exclude the patient.
Right. And I know there are two C3 drugs. There is the pegylated, which is the AMY 101, right? And the Apellis is non-pegylated. Is that correct?
No, they're both pegylated.
Pegylated. Okay.
Yeah. So they're both, basically modified versions of compstatin.
Yeah.
But the modifications made in the two are not identical.
Because the question did ask that because it requires daily dosing. I don't think that's right. It's twice a week.
Yes, and I think the confusion is because a prior formulation of our drug, we did do daily dosing, but the current trials and the approved version for PNH is twice weekly.
And that's because of the modification that makes it longer acting. Is that why that is, or how did you guys achieve that?
Yeah. So the modifications are not actually what enabled the twice weekly, but the modifications are, the challenge in using a C3 inhibitor is that C3 is a very abundant protein. And so you need to have a lot of drug in the system in order to effectively inhibit it. And so the modifications really focus on two things. One, trying to improve the affinity of the drug, for the drug to C3. But even compstatin has pretty high affinity, so there's not a lot of room for improvement there. But then the second thing is to improve the solubility and basically the bioavailability of the drug. And so that's where the pegylated part is important. And then in terms of being able to do daily versus twice weekly, it actually has more to do with the excipients that we used within the formulation.
Gotcha.
So a couple more last minute questions that have come in. Some about the patient screening and participation and potentially, like I guess, screen failure type rate. How many patients are willing to participate, or can you just give a rough estimate on overall enrollment and things?
So I guess I can't speak to how many patients are willing to participate. but I guess in terms of overall enrollment, so we've been enrolling for the post-transplant study for a few months now, and we've just started, literally have just activated the phase 3 trial in the United States. We are still looking for more patients for the NOBLE study. And we can, you know, if you follow the links or if you go to clinicaltrials.gov, then you can see the list of sites, both in the United States and worldwide. I will say that if there's a patient who's interested, and even if they're not, you know, immediately accessible to a site, we will provide support for travel, and try to make it as convenient as possible for the patient so that they can participate if they wish to. And then I also actually saw there's a question about pediatric sites. So maybe I'll just answer that now while I'm talking about sites. So yes, we have sites that where a pediatric nephrologist will be the principal investigator. We also have sites where, you know, what we're trying to do is that at every institution, we're going to try to make the most of that site and be able to enroll patients at a given institution that are adult, pediatric, transplant, non-transplant. So as we identify sites, then we're trying to work with each site to say, okay, how can we maximize the opportunity at your site, right? Because I would hate to make a pediatric patient who has a site that's an adult site in the same city as them, then travel to another one, or they have the option. But so we're trying to make each site as broad as possible, but also have a spectrum of types of sites.
And then we have a question, I believe, from Dr. Lau. So I'll ask, you can unmute and ask.
Okay, great. Thank you. Thank you so much, Hetal, for your presentation. I have two questions. The first one is, if you can just clarify for inclusion into the nobility study, the NOBLE study, is there a requirement for the C3C staining on the allograft biopsy for that to be present before we can enroll? So that's my first question. And my second question, again, also pertains to the post-transplant patients. You know, as you know, they're going to be on MMF, they're going to be on CNI and possibly on steroids. And then on top of that, we're adding this complement blocker. I suppose we have absolutely no safety data at all at present in this population of patients that we might consider this drug for.
Okay, so oh my gosh, I just spaced on your first question. Say your first.
It was about the C3C staining for inclusion.
Yes. Okay. So for that question, so if a patient has a baseline biopsy and they have at least 2+ C3C staining on that biopsy, then that would meet that eligibility criteria of ongoing or active, ongoing complement activation or active renal disease. So that's yes, we would require that for both the transplant and non-transplant.
But I don't know of our pathology labs, because you had made the comment that, you know, the staining for C3, I don't know if it encompasses specifically C3C versus
yes, and so
C3D or other, you know.
Right. And so we would do the staining at our central pathology lab. So you don't need to worry about that. So as long as the patient meets all the other criteria, so you can screen the patient, make sure the patient meets all the other criteria, and then do the biopsy as part of the study. Or if you've already done a biopsy recently, then we will work with you to have our central pathology lab either, you know, review what you did, find out what antibody you used, redo the staining on frozen sections. Like, we'll work with you to do everything we can to avoid a repeat biopsy if we can.
Oh, I see. So you will take our tissue at entry or at screening, and you will process it to be sure that you have this, the C3C. I just want to make sure I understand that. Okay, I understand. Okay. And now on to the second question. Yeah.
Okay. Yeah. And so ideally what would happen is you would screen a patient, they would get the blood work, they would, you know, have all inclusion, exclusion assessed. If they meet everything, you would do the biopsy as part of the study. That tissue would go to our central lab and be processed there. Okay. So then the second part of the question, and can you repeat that for me again? I'm sorry.
Oh, it was just about safety data on post-transplant patients that are obviously on other maintenance immunosuppressive agents.
Right. Okay, good. So yes, of course, the post-transplant patients are likely to be on various immunosuppressions. And while we do not have data on post-transplant patients per se yet, the NOBLE study will start to collect that. We do have patients, both PNH patients for that matter, but also even in the discovery study, who at least were on steroids and or MMF. And then had pegcetacoplan added to it. And so as best as we can tell, again, it seems to be well tolerated based on the data we have to date.
Okay, thank you.
And I think Dr. Randhawa has a question. You can
I have a
unmute.
suggestion, not to restrict the participation to 2+ staining. I mean, as it is, you're going to have difficulty recruiting patients. And I don't think 1+ and 2+ are all that different. It's in the eyes of the beholder, and also the staining intensity can vary from day to day.
Yeah, it is a good point, and that it is not, it's a semi-quantitative result. It is in the eyes of the beholder, very well said. And so I guess the real reason to require the 2+ C3c staining is because one of our key secondary endpoints is a reduction in C3c staining. And so if we allow only 1+ C3c staining, then we further undercut our ability to actually look at a change. And it's a challenging endpoint as it is for all the same reasons that you've just articulated. So it's a tough choice that, I can see arguments in all directions. So, your comments appreciated, and I'll definitely keep thinking about it. It's a tough one.
Of course, 1C can fall to 0, and that could be significant,
Yes. Thank you.
And then Dr. Glassick had asked if you'd be staining the 26 and 52-week biopsies for pegcetacoplan deposition in the glomeruli.
For deposition of pegcetacoplan itself, the drug, or?
I think so, Dr. Glassick, is that?
He must be asking about C3 deposition at those times, right? Or is he?
Yes, that is the question. Will the drug be deposited in the kidney like eculizumab is?
Okay, so this is a good question. So are we staining for pegcetacoplan itself? No. I don't know that we actually have a method to do that, but we will obviously be looking carefully at the renal biopsies. There are, so what I will say is that what's well described is that pegylated compounds can lead to some changes in the kidney. And at doses higher than we're using in our clinical studies, when we give high doses to animals, you can see some of these changes in the kidneys of animals. So this is obviously like in PNH, we don't do renal biopsies. So in this study, we'll be doing renal biopsies. And so they will be, carefully evaluated and sort of looked at in a general sense, in addition to looking for the C3c staining and the C3G histologic index. So if there are any changes suggestive of something related to the drug, this is something we'd be in a position to identify.
All right, thank you. And I think we talked on some of these trials aren't going. So as far as the question regarding relapses when stopping, I think it's something that will be being looked at from what you had said earlier.
Yeah, so I mean, as part of the study, if patients, if patients stop the study drug, then they will go through a follow-up period. So we'd be able to evaluate that. And then, in terms of the question about whether there are any consequences upon stopping the drug or missing the drug, then those are things we'll look at as part of our safety evaluation.
All right, excellent. Well, we've gone a little over with an excellent presentation and a great discussion. So thank you, Hetal, thank you, Anuja and Marina, for joining today. This is great to shed light on this, and I know eager to enroll patients in these trials and things so we can kind of advance our treatment for them. So thanks again, everyone, for joining, and thank you for what an excellent presentation. We'll have it posted in a couple of weeks online to review, or for those who weren't able to see it. So thanks, everyone.
Thank you. Bye.
Thank you.
Bye.
Bye-bye.
Bye.